Melanoma, a malignant tumor of atypical melanocytes. Melanoma is the third most common cancer, where 92% of the reported cases involve the skin, whereas it is rarely reported in the oral cavity. Risk factors include intense sun exposure or artificial ultraviolet radiation exposure, having a fair complexion or individuals with light-colored hair and eyes, then having a history of blistering sunburns or a family history of melanoma or a congenital nevus. Lastly, individuals with mutation in genes like cyclin-dependent kinase 4, melanocortin-1 receptor gene, and cyclin-dependent kinase inhibitor 2A have a high risk of developing melanoma. A normal basal cell layer may appear like this, with a regulated proliferation of both the basal cells and the melanocytes. However, the presence of certain risk factors may disrupt the harmony. Various molecular and genetic studies report that in approximately 50% of the cases of melanoma, there is a mutation in a gene encoding BRAF. BRAF is a protein kinase that is involved in RAS-RAF signaling pathway, a disturbance to whom results in proliferation of atypical melanocytes. Melanoma is seen mostly in white adults above 45 years of age with a male predilection and four variants. The first variety being discussed is superficial spreading, which is the most common form of melanoma. The most commonly affected sites include interscapular area in males and the back of legs in females. The second variant is nodular, which is the most aggressive form. It is thought to begin almost immediately in vertical growth phase. Clinically, it appears as a nodular elevation and rapidly invades the connective tissue. Lentigo maligna is the third variant which develops from precursor lesions, also known as Hutchinson's freckles. It accounts for approximately 5 to 10% of the cases of cutaneous melanoma, and this variant has the longest duration of the radial growth phase, which averages to about 15 years. Clinically, it presents as a slowly expanding macule on sun-exposed skin of fair-complexioned older adults. Lastly, acral lentiginous, which is the most common melanoma in oral cavity and black population. In this variant, early lesions may be flat, which later turn nodular. Here, intraorally, most commonly involved sites include hard palate and the maxillary alveolus, while other extraoral sites are the palms of hand and soles of feet. Histologically, you will observe atypical melanocytes at the epithelial and connective tissue junction. These atypical melanocytes may show a radial growth, that is, melanocytes spreading horizontally along the epidermal connective tissue interface. While in the vertical growth, the melanocytes spread vertically deeper into the connective tissue. Histologically, the superficial spreading variety exhibits a pagetoid spread, that is, single tumor cells infiltrating into the upper layers of surface epithelium. While in nodular melanoma, vertical growth phase occurs very early in the disease and no radial growth phase is observed histologically. In the acrolentigenous variety, it is observed microscopically that the melanocytes have prominent dendritic processes. The immunohistochemical analysis of an individual with melanoma will exhibit a positive result for S100 protein, HMB45, Melan A, and microphthalmia-associated transcription factor. For a colored lesion to be suspected as melanoma, we look for A, B, C, D, and E, where A is asymmetry, which could be because of uncontrolled growth. B is border irregularity, which is often seen with notching. C is the color variegation. The lesion may vary from shades of brown to black, white, red, and blue. D is the diameter, which is, if greater than 6 millimeters, could be suspected as melanoma, while E, evolving, a lesion that has changed with respect to size, shape, color, or surface, or any symptoms over time, could be thought of as a case of melanoma. For the treatment of melanoma, surgical excision remains the mainstay of treatment. For a tumor that is of thickness of 1 millimeter or less, 1 centimeter margin clearance is indicated, while a deeply invasive tumor requires 2 centimeter of margin clearance. High doses of interleukin-2, dacarbazine, and imatinib, etc., are considered in patients with distant metastasis. Adjuvant radiation therapy and immunotherapy with interferon alpha is considered in patients with high risk of recurrence.